Dr. Sean Lyden is going to continue with the talk about this algorithm of treatment of SFA disease. He's going to talk about the PTAB, or the percutaneous transvenous arterial bypass. Sean?
So thank you very much to the organizers for inviting me. Here are my disclosures. So I think we just heard from Eric, there are a lot of options out there. How do you decide? I also try to look at all these different things in terms of claudication, critical ischemia, the runoff status, if there's a surgical option, how calcified it is, what the patient's medical risk is. And I'd agree with them. There's very little head-to-head data. We know that DCB is better than POBA, improves patency by about 20 to 30%. DES is better than nitinol stents, but there's downside to stentings. The newer generation stents are better than the first generation stents. DS and DCB outcomes are mostly equivalent among the brands that are available today, in my opinion. And I think that depends on your religion and what you think the lesion looks like of the ideal vessel prep, and I think it really depends on the skill in your hands. But I think the thing we can all agree with is that when you get to the long lesions, the outcomes really start to drop off when you get to the 20 centimeter long plus lesions. And so before I say how do I work PTAB into it, this is kind of how my religion goes. So I generally do vessel prep, whether it's atherectomy, angioplasty, or lithoplasty. If it's failed or suboptimal, then it's going to be generally scaffolding with the Sapera drug-eluting stent or covered stent. If it looks really good, then it's if it's short, it's length or short occlusion, or it's not super calcified, it's going to be drug-coated balloon. If not, it's going to be scaffolding that's drug-eluting or Sapera with the drug-coating balloon. And then I've gone back and forth in my career, depending on where the data is. I've generally been less metal is better than more metal, but there are times when sometimes it just needs a lot of metal to get it to work. But we all know that the long lesions are certainly different. I can serially take 2, 3, 4 hours, start from above axis, below axis, sticking through stents, and I can treat it endo. But it doesn't work really well, and I think bypass clearly still works. If we look at the data from what we just found out from the surgical trials, bypass still does work, and I do get vein mapping on my patients, and I do consider bypass, but, let's be honest, bypass patients, there's a 30, 35% wound infection rate. A lot of times they're coming back to the office for a lot of things, and from the time that I was in training 25 years ago, we always taught save the vein, use prosthetic, but we know prosthetic doesn't work nearly as well, but there are those patients that it might actually work for, and so the detour procedure, or PTAB, was really designed to do this all percutaneously. So for those of you guys who haven't seen it, you basically needed a nub of the SFA. You cross from the SFA through the femoral vein and then cross back into the distal SFA or pop-T artery with a unique proprietary crossing device, and then a purpose-built stent graft that has good radial force. The proximal 5 millimeters is an uncovered segment. There has been 2 trials, both the Detour 1 and Detour 2 trial, that looked at the data. So if you're going to talk about how it works in algorithm, you got to know the data. So it treated roughly 3 to 5 patients with at least a 20 centimeter lesion length. That could be a CTO, a restenosis, or an in-stent stenosis. And because of the sizes of the devices, your reference vessel distance had to be 4.5 to 6.7. You had to be able to get in the stump of the SFA. You had to have a patent landing zone with 1 tibial runoff. And because you went through the femoral vein, it could either be duplicate or greater than 10 millimeters. So this is kind of the patient you're looking at. You can see there's a tiny stump of the SFA. There's a long lesion that comes all the way down past the adductor hiatus and ending right above the tibial plateau. The venous anatomy you can't underestimate. If you have a femoral vein, you put the 6.7 millimeter stent graft in it, it's not going to impact outcomes. If it's duplicate, you still have one, so it's not going to impact outcomes. But however, if it's small and you then put this in it, you can actually limit the flow and have venous issues. So those were excluded from the trial. If you look at the the Detour 2 trial, I think a couple things you want to point out. The patients look very similar. Most of them are claudicants, 77%. But if you look at the number of total occlusions, 96% were total occlusions, 97% were diffuse stenosis. The normal to normal lesion length was 32 centimeters. So these are not the sort of patients that are going to be quick in the OBL, quick in the office. These are complicated lesions. The other thing is, if you look at how it was defined, the patency through 2 years was 59%. And people say, well, that's not so impressive. But, I think you have to look at a couple things. So the freedom from clinically driven TLR was 76%. So there was a patient really symptomatic that they need treated. And the other thing we know from surgical literature, that when we do a prosthetic bypass, it can look perfect today and come in tomorrow thrombosed. So we know that duplex is not super sensitive to say, will these actually fail? And if you looked at whether these procedures were patent or not, so they had flow or not flow. At 2 years, you can see the patency looks very different than what duplex-derived patency is at 87%. So this is, once again, putting them next to each other, C-delta-R, and then the absence of flow versus non-flow. You can see that, hey, 87% of these are actually open. The other thing is it's safe. The freedom from symptomatic DVT was 96% of patients, and the freedom from major amputation was 98.5% of the patients. So it's durable. You look at the major adverse event rate, freedom from it's 73%, with a secondary patency of 82.3%. So here's where it boils down. So endo, if I have a 0 to 15 cm long lesion, I am doing it. Endo, I'm going intraluminal all day, every day. I think the more calcium and the more of a CTO, the more likely I'm going to be stuck with a scaffold, depending on whether that's either drug-eluting or going to be Supera. But I think PTAB clearly has a role in my practice for those long CTOs. That person's already been stented who has a stent occlusion. Those patients have that super dense calcification. It should be something that we should start thinking about for complex lesions over 200 millimeters in length and clearly over 300 millimeters in length. And if you look at how it works, the freedom from tardive vessel revascularization was 79% at 1 year, 68% 2 years, and it really has really low major adverse events rates and DVT rates. So thank you.